I learned that I can be strong and I can be powerful even when I'm feeling pain. And to me, that changed the relationship of I can be a doctor and I can be good at my job and I can love my work and be someone who has pain.
So today's guest is Dr. Julia Rhodes. She's a psychiatry resident, chronic pain researcher, and really a relentless force in medicine. After a spinal cord injury left her paralyzed, she developed chronic pain and realized quickly that the current medical model isn't actually equipped to treat these kind of conditions. So she's here to tell us her story and what she is doing to change the system for good. Welcome, Dr. Rhodes.
Thank you for having me. I'm excited to be here.
We're going to have fun with this one. So first, I want you to kind of give me whatever you feel comfortable of a backstory of where you currently are and where you've come from.
Yeah, I am a third-year psychiatry resident at the Medical University of South Carolina here in Charleston, South Carolina. I had a spinal cord injury in 2013 and then went to medical school here in Charleston, South Carolina. I stayed here for my psychiatry residency. In my third year in medical school, my pain, chronic neuropathic pain that I have with my spinal cord injury started to change. I realized that I was gaining back sensation, but what the sensation that I was gaining back was actually pain.
So you're going through school, going this, and then this intense amount of pain comes on for you. And
yeah.
Did that limit you in your ability to actually practice or to attend school?
So my acute on chronic pain, or what we would call it, these episodes were completely debilitating. I would wake up and begin to cry. But what was the most debilitating part of it wasn't actually the pain itself, it was the medications that I was on. The medications that you use for neuropathic pain are very sedating. And I don't know if any other doctors feel this way, but being sedated and being tired is not something that you can do in complete medical school. So I began to have to stop taking pain medications in order to complete my rotations.
Wow. And I honestly, I'm sure that majority of doctors that do prescribe it have never actually experienced that kind of pain themselves and understand in a personal level its sedative effects. So for you, it was kind of experience the pain or get through school. And so you had to make a decision.
Exactly. The places that I went to try to get more help, try other options, there's not a lot of evidence for treatment of neuropathic pain outside of these medications. And so I found myself being on my rotations, wearing ice packs in my scrubs, wearing ice packs in my wheelchair to be able to make it through the day.
Why do you think that is? Why do you think that we're so limited in treatment of neuropathic pain considering its prevalence?
What I've learned in my research with pain and chronic pain is that our ways to treat pain haven't changed very much in the last couple hundred years. And that's because the Western model of pain treatment is to get rid of it, to end it, to remove it. In Eastern culture and Eastern medicine, they're taught how to live with pain. That pain has a role to play in medicine just the same as healthy tissue does have a role. And treating pain looks more like understanding and learning from it. In Western medicine, our approach is to live without pain, which is especially with neuropathic pain, which can be a moving target. This is almost an impossible thing to, a sort of a fruitless endeavor because you're continuing to chase a pain symptom that's never going to fully resolve.
Oh, wow. That's interesting. So it's really the expectations that change the outcomes.
Yes.
And for you, as someone that's trained with a Western medicine background, were you having the expectation of becoming pain-free? Or at what point did you realize that might not be possible?
I thought that I couldn't become a doctor and have this pain. I thought I needed to be asymptomatic, really, to become this doctor. And there's, the ableist view of medicine of this doctor as someone who's physically fit in the model of health. And so I was already entering into medicine not fitting that model, being paralyzed, being in a wheelchair, but I thought that I also had to be asymptomatic from any pain, and that pain would limit me in that way. So I chased trying to get rid of the pain first, and that I couldn't move on without getting rid of the pain. And I continued to, as I continued to study and as I continued to learn more about the pain pathways in our brain, I learned about the differences of acute versus chronic pain. And for any pain patient, no matter how long you've had pain, every pain episode feels as bad as the worst. It feels completely debilitating and you feel stuck and helpless. And I think a lot of doctors also feel that stuck and helpless feeling when they are working with these chronic pain patients. And I wanted to know why. Why is somebody waking up with 12 out of 10 pain every day? How is that possible? And so I learned about the pathways. In chronic pain and acute pain, it starts the same. If you stub your foot, that pain signal goes from your ankle all the way up your leg into your spinal cord. And then in your spinal cord, it meets the second neuron. And that neuron takes it all the way up the spinal cord until the back of your brain, until your brainstem. And then in the brainstem, that's when things get really interesting. This is the part that I think is fascinating. From the brainstem, it goes and travels like a ping pong ball all through your mesolimbic and so your emotional part of your brain. It travels through your memory parts of your brain, and it goes through almost like a ping pong ball going in the arcade until it reaches that frontal lobe of awareness. So before you even know you have pain, that signal has traveled through your memories. It's traveled through all these other parts of your brain, your emotional side. So it's almost like a color run. I don't know if you've ever done a color run. They're very fun. Yeah. You start out with this plain white t-shirt, and then by the end, it's just covered in all, you and the plain white t-shirt are covered in all different colors of chalk paint. If you think about this like a color run, that pain signal that left the foot, it starts off as a plain white, maybe 3 out of 10 pain, white t-shirt. But when it travels up, and then by the time it gets through the brain, it's going to go through your learned experiences of pain, starting from when you were a kid. And did you learn pain as in you learned that someone's going to come and rub your knee and give you a kiss and put a Band-Aid on it? Or did you learn rub some dirt in it and you better not cry? Then it goes through your emotional side, all of your mesolimbic part of your brain to say, like, are you already in a stressed, anxious state? Is your amygdala already overactive? Because that's going to change the pain signal too. And then by the time it gets back up to your frontal lobe, before you even know you have pain, that pain signal has been manipulated and changed and been splattered with so much paint that now it's an 8 out of 10. And you didn't even know that it had started out as a 3 out of 10.
Oh, wow. Really interesting. So to be clear here, you're talking about this is the same pain experience, acute and chronic. This is the starting steps of it, right?
Right. This is the starting steps of it. This is acute and chronic. What happens over time is that the parts of the brain that get ping-ponged, that get this signal, they start to have structural and chemical changes. The longer they have a pain signal shooting up the brainstem and ping-ponging them, it's almost like they start to get fatigued because the pain signal is keeping coming, but there's nothing that they can do about it. So one area, the ventral tegmental area, its role is to spit out dopamine. So it spits out dopamine, and we need dopamine for a lot of things. And the biggest thing that we need dopamine for, a big thing, is to feel any reward or motivation. So as the pain signal keeps going up, the ventral tegmental area starts to slow down how much it spits out dopamine. So it gets super hyperactive, and studies show that it gets super hyperactive, but the brain starts being in a decreased dopamine state, a hypodopaminergic state. One of the things that's interesting is if you think about patients in chronic pain and you tell them, you know what's really going to help? Physical therapy. And you just see their faces fall. They don't feel motivation. One of the reasons for that is that they are in a lower dopamine state. And so the other areas of the brain, the amygdala, the anterior cingulate cortex, the prefrontal cortex, these areas are hyperactive, but they also show that they get smaller. These are physical changes that happen to the areas in the brain that look a lot like someone who has depression. It's almost as if the brain becomes in a depressed state with chronic pain.
Oh, wow. That's super interesting. So it's that repetitive signal that's going to the brain at first causes a hyperactivity, but then there's almost a downregulation where some of the structures will actually get smaller and their ability to produce, for example, the dopamine decreases, leading to these other symptoms. Okay. Wow.
Exactly. And to add injury to insult, one of the things that dopamine does too is tell our spinal cord to spit out GABA. And GABA helps other pain signals. It helps suppress pain signals in our spinal cord. Our brain tries to suppress. But when you don't have enough dopamine, you also don't have enough GABA. So the longer you're in pain, the more sensitive your body becomes to any other pain signal.
So within this process, at what part of this pathway does something like a gabapentin affect it?
Yeah, so gabapentin works at the level of the spinal cord and in the brain. It's replacing the GABA that the brain would have been using if it had enough dopamine. So it is there in the spinal cord to try to help suppress the pain signals.
And so for you, is it fair to say that, or I don't know if you were taking that or something similar, but it wasn't.
Yeah.
You were? Okay. So, and then it wasn't that effective for you maybe because it's more than just the decreased release of the GABA, like because there's all those other pathways that are going on? Is that right?
Exactly. It's because there are all those other pathways, and to have the dose that would be therapeutic for my pain, it was also too sedating for me to be able to have through my day.
So at what point did you realize that the system itself didn't have the answers that you were looking for to have tolerable pain, but then still carry out the duties of a doctor?
It was my third year of medical school that I realized that if there was going to be a solution, I was going to need to create it myself. I think at all stages of training, a physician, a medical student, or then a resident can become disillusioned with our system and how broken it can be, and people find other ways to cope with this. My way was to get creative. I realized that I was looking for one solution for my pain. And in medical school, I learned something called the biopsychosocial model of medicine, which is to treat every illness has components of the biological, the psychological, and the social elements. And when I learned about this, I also learned that pain almost has very similar three elements. It has the biological, the physical, the pain experience. When you experience pain, you experience it in three parts. You experience the physical sensation of the pain. You also experience your affective distress, how you express distress from that pain. And then you also have your learned experience of pain, how you respond to it. So when I saw both these frameworks, it sort of, for the first time, helped me see this monster that I was carrying on my back, and I had like tangible edges to it I could grab onto. I saw, okay, we have the biological part of this. We have the psychological, the affective distress part of this. And then we have this learned experience or the social part of this. Okay, maybe I've been looking for one solution was the problem. Maybe I need three.
Okay. And so what was next once you came to that realization of maybe I need more than just the medication? What was the next step for you of exploration?
Yeah. So I learned that let me start over. I realized that medications was not going to be something I could tolerate. And especially as I got more and more distressed by pain, I saw how good I felt on narcotic medication, and I saw how dangerous that could be. And I realized that I needed another solution than pharmacological. So I met with our neurosurgery department here, and they took on my case and they implanted a spinal stimulator, which works by interrupting the pain signal on the spinal cord. We have nerves that have different roles on our skin, on our extremities. Some sense temperature, some sense vibration, some sense pain, some sense touch. And the signals for vibration and pain you can manipulate because one is faster than the other. So vibration is the faster signal than pain. If you ever hurt your knee and then you rub it and that makes it feel better, it's because the vibration moved faster and it blocked the signal. Only one can get read at a time. I met with the neurosurgery team and had a spinal stimulator in place. And so for me, that to me was the solution for the biological part of my pain and the body part.
Okay.
Then I worked in my pain research. I learned about acceptance and commitment therapy, which is a newer model that's built on the framework of cognitive behavioral therapy, but moves a little further to say, we don't need to always be fighting with these cognitive distortions or these experiences, but learning how to live with them, having a different relationship with them. And so I learned that I had been so afraid of pain, of it coming back, of the next time I would have it, that I was avoiding things to avoid pain. I would go to class, I would go to do my rotations, and I would come home, but I wouldn't see friends, I wouldn't do anything else because I didn't want to make that pain worse. What I learned in acceptance and commitment therapy is that I was depriving myself of the dopamine that I would get from seeing my friends, as well as continuing to ensure that my pain didn't get better, because even if I stayed at home, I wasn't doing anything that made my pain better by staying at home. I was just preventing it from the chance to get better. And then I needed to change my relationship with pain itself. And I needed to change my relationship with myself as somebody who is not suffering from chronic pain, is someone who's not being held back by pain, but is someone who's strong enough to live with pain. And that was the key. Here in Charleston, we have the most amazing rivers and marshes, and you can be in the water for hours without being out in the ocean even. So for twice a week, for months, I took myself into the water and paddled in a kayak with a friend, because I needed to be in the water where I could ignore my lower half. When I'm paddling, I have the same capabilities as an able-bodied person. And so it was important that I didn't medicate myself before I did these activities, because it was important that I felt my lower half be in excruciating pain. And then I also felt my upper half pushing the paddle into the water and pulling myself forward. I could feel the strength in my body, in my arms, while I simultaneously felt pain in my lower half. And I could feel myself pulling myself through this. And so I learned that I can be strong and I can be powerful even when I'm feeling pain. And to me, that changed the relationship of I can be a doctor and I can be good at my job and I can love my work and be someone who has pain.
This is such a powerful story. It really is. And so, it took a lot of exploration for you to find these. This wasn't something that you figured out overnight, obviously. What do you think we need to maybe change within the healthcare system so that our providers are better equipped to provide these solutions to patients earlier on?
Yeah. So I do a lecture with medical students because something that I felt when I was an intern that I know other people have felt too is feeling the powerlessness of having a patient coming to you, asking you to remove their pain, and you're not quite sure what you're treating. You know you're treating pain, but is this more the patient's personality? Is this pain has been going on for a long time? Why now? What I teach and what I preach is to change the dialogue. We have inherited into our practice this problem that happened with the opioid epidemic of teaching patients that the solution to pain is to get rid of it. And we unfortunately cause so much harm with opioids by reinforcing that idea. And now it is our time to sit with patients and tell them we can't get rid of your pain. I cannot make your pain go away. I can help you learn to live with it, and I can help you learn to carry it and it not interfere with your life. I can help you learn to be functional with it.
It's a totally different conversation that can be really challenging. Me, myself, as a physical therapist, I have treated hundreds and hundreds of people in pain. And having that conversation with them and setting up the expectations, one of my favorite questions to ask them is, what level of pain can we get you to where you'd be happy and you'd say, okay, I can live my life this way, right?
Exactly.
And, instead of saying, okay, let's figure out what it takes to get you pain-free, and then if they don't get there, you're setting up for failure. It's like, what if we brought your pain from a 7 to a 4? Would you be happy? And they'd say, yeah, like I would love to be at a 4. Setting that expectation is so big. And it's so cool that you're explaining to them and kind of teaching these residents how to have that conversation. Is there any ways, because like, for example, when you were explaining it to me, I love nerding out and you were talking about like the neuroscience behind it. But what about for the lays person? How do you like to explain this to them?
I like to say that pain is a signal. And our chronic pain is also a signal of not just what's happening in that limb or that area of the body, but also in your brain. And what we need to do is listen and respect the signal. My work with you is not going to help you get rid of the pain, and it's not going to help you ignore the signal. My work with you is going to help you gain the life that you feel like you're missing out on and regain the functionality that you want and enjoy your body while that signal bleeps every once in a while. I try to explain that our pain is an energy within our body that we can use.
I love that. Yeah, absolutely. I think one of the analogies that I've used with my patients that's been really effective is thinking of the way that we process pain, which we process it in our brain, of like a smoke detector. We've all had a smoke detector in our house that always goes off, where it's like it keeps chirping at us, right? And our natural instinct with that is to be like, how do I turn this thing off as quick as possible? And we get to the point where we bring a chair over, we get up to it, and we take the battery out of it, and then it stops. Now, great short-term solution, and this is how, for example, an opioid could work, because it can block off the pain. Now, the challenge is that what if you have a fire in your house? Then what happens? Your smoke detector's not working. And that's where it plays a role. Like, you want it to be working. You want it to be giving you that feedback. Instead of taking the battery out, let's look at different solutions. Maybe while you're cooking, maybe you can open a window. Maybe we can install a vent. Different ways like that we can look to apply to your life so that they can still be part of it, but providing value at the same time. Does that make sense?
I love that. Yes, that's what a great analogy. That's exactly it. Yes.
I think that's the goal, is to make sure that they can relate to some everyday thing for them, which is super important. So For you, what's your vision now? Like, as you finish off your residency, like, what do you want to be known for?
I hopefully will be known for walking with my patients and helping them through their journeys. I am so grateful that I had the support and the education and knowledge to be able to have my pain be part of my life that I can still practice, because I love psychiatry and I love my pain research. I'm hoping to be able to continue to do pain research because I think we are at a precipice of change with it. We have learned what has not worked, and now we have a great potential to make some headway after, now that we're hopefully seeing the tail end of the opioid epidemic. Things have been going really well, and we still have a long way to go, but now I think is the perfect opportunity to have these different dialogues with patients. And so I'm hopeful in the pain research that I am doing, I can continue doing it. I hopefully will be going into the VA. They helped pay for part of medical school, and as a proud Army wife, I am very excited to be hopefully taking this research into the worlds of veterans who experience a lot of chronic pain themselves.
What excites you most about that research?
Everything that we're learning about pain uncovers a different layer to the complexities of the brain. And how lucky are we to be able to be in an age where we can see the changes that happen in the brain while we are treating an illness. And the more I learn about chronic pain, the more I learn about the complexities of humanity and how our personalities shape our responses and how our interactions as kids shape what we are going to be, how we're going to be reacting to our adult lives. And I think it's not going to be the next injection or the next surgery that brings a miracle to pain treatment. I think it's going to be new understandings of how humans can treat each other that's going to help us solve a chronic pain problem.
I love that so much. So if another healthcare provider is listening to this conversation and they say, you know what, I'd love to talk to Dr. Rhodes or kind of learn about her research, where could they go? What's the best way to get in contact with you?
Yeah, I'm available on LinkedIn, and that's a way to be in touch with me. I'm also on Instagram, but I would love to chat. I'm at the very beginning of my career. I'm entering into my last year of residency and starting to have these relationships where I'm very, very excited to be part of the chronic pain conversations on a national level moving forward.
That's amazing. Well, I can't thank you enough for taking the time to sit down and share this and share your experience. I know this is only the beginning for you, and we're going to have to start doing annual conversations so I can learn about the advances that we're making in pain medicine, if you're cool with that.
I would love that. Thank you so much for having me.
Of course. So, if you are a healthcare provider that's listening to this and is trying to find ways to push medicine forward and disrupt it in a positive way, then make sure to reach out to us at MedStory. We want to share the stories of the providers that are doing it just like Dr. Rhodes. And until next time, we'll see you in the next episode.